Well, good afternoon, everybody. I'll just wait till it's 12 and then we will formally start this second seminar session. Well, it's 12 now. So I'll introduce myself. My name is Jacqueline Whelan. I'm a professor here in the School of Nursing and Midwifery in Trinity College, Dublin. And I'm also the chair of the Spirituality Research and Innovation Group. You're all very welcome to this session this afternoon. This is the second seminar in the series Revisioning Spiritual Healthcare. And today I would like to present to you Professor Melanie Rogers. Now, Professor Melanie Rogers is a very good friend of mine. We have worked quite a lot over recent times. And she is an internationally renowned advanced nurse practitioner and clinician, an educator and researcher. She's a professor of advanced practice and spirituality at the University of Huddersfield in England, as well as a national teaching fellow in these areas of specialism. She works clinically as an advanced nurse practitioner in primary care. And Melanie is actually the director of the ICN Nurse Practitioner and Advanced Practice Nurse Academy, and she has served as chair of the network for the last 5 years. Her international work and collaborations are extensive and very well developed, and she was presented with the Queen's Nurse Award for her work in practice and education. And she also holds international certification as a global nurse consultant. So suffice to say that Melanie is very, very passionate about the work that she does as a way of providing care needed at a direct point of need for patients that she actually works with. So Melanie, I would like you to commence your seminar, and today's title is going to be Emotional and Spiritual Wellbeing and Resilience of Advanced Nurse Practitioners, based on a global study that Melanie recently completed with a team of other researchers around the globe. So you're very welcome, Melanie. Thank you.
Wonderful. Thank you so much, Jacqueline, and absolutely delighted to be with you all today. I understand we have a mix of clinicians, educators, and researchers. And as Jacqueline said, my passion really is about the development of advanced practice nurses, nurse practitioners. And in the UK, we have advanced clinical practitioners. So we've opened up the discipline for other health professionals. And I'm delighted to take any questions at the end in the chat, and Jacqueline will ask me. And I've also left my email if anybody wants to contact me. So Jacqueline told you all about me. What she didn't tell you is I have 2 little sausage dogs who hopefully are fast asleep behind me. Where if nobody knocks at the door, it'll remain quiet. If we have any visitors, the little one might make a little bit of noise, but I'll try and keep her quiet. As Jacqueline said, I've been involved with the ICN Advanced Practice Nurse Practitioner Network for the last probably 20 years, and I was the chair before Daniela Leyveld, who's one of your Irish colleagues, and I've been involved in the Academy of Research and Enterprise. I'm also still practicing clinically. I work in primary care, did a clinic last night, and also did a clinic with my students to allow them an opportunity to see what primary care was like, their secondary care background. And I'm also heavily involved in the International Network for the Study of Spirituality and chair their Spirituality Scholars Network. I have had a passion for holistic practice for all of my career. I'm very, very committed to holistic care. And I have my little sausage dog just below me now, jumping up, who I will move to the chair, and hopefully she will go back to sleep. So apologies about that. So I'm going to tell you a little bit about the research project that myself and colleagues undertook through COVID. And then I'm going to talk a little bit about well-being and resilience. And this is an area that I'm really interested in. I'm not sure I love the terminology of resilience, because it seems to imply that the onus is on us. And a lot of time within a healthcare, there are so many factors impacting our resilience, and organizations have a huge part to play. But we'll talk about that as we go through. I'm going to talk for probably around 40 to 45 minutes. And then, as I said, we'll have time for discussion, questions, and any comments that you have. So there's two projects that I've been involved in. One was a global project looking at advanced practice nurses' emotional and spiritual well-being and resilience through COVID. And that was undertaken with colleagues in Canada and the US. And you'll see there the list of our team. I also undertook a study in the UK, particularly looking at advanced clinical practitioners. And if you want to know more about that, I can send you the link for some papers. But that was looking at not just nurses. We also looked at paramedics, pharmacists, OTs, physiotherapists who were undertaking the MSc Advanced Clinical Practitioner course in the UK or who were qualified. So both of these studies had exactly the same methods and methodology. But obviously, COVID was a big shock for all of us. We had to respond very quickly to the transitions that were needed. We also had to had the opportunities to show how transferable our skills were, and also to work at the top of our scope of practice. And very, very early on, I was aware of how colleagues were being impacted in terms of their well-being and resilience. So I wanted to bring together a team to begin to look at what the impact of COVID would be quite early into the pandemic, probably about 4 to 6 months, and then also repeating the study around 18 months later. So we undertook a cross-sectional mixed method study via Qualtrics. We sampled APNs globally through social media, through professional organizations, through the ICN, and we used snowball sampling, so allowing people to pass the invite for participants on. We utilized 3 validated surveys. The Warwick and Edinburgh Mental Wellbeing Scale is really looking at subjective mental well-being. The Functional Assessment of Chronic Illness Therapy, simply known as FACIT, has several measures for spiritual well-being. One of them focuses on patients, but the one we used was looking at healthcare professionals. And then we used the Connor-Davidson Resilience Scale, the CD RISC, to look at trait and psychological resilience. We were really delighted to have such a large participation across 53 countries. In phase 1, we had 928 responses. Unsurprisingly, that dropped in phase 2 as people became more weary, probably not really interested in participating as much in research studies, and were struggling with burnout, well-being, compassion fatigue. The UK study, we also had 783 ACPs, and that dropped a little bit in phase 2. But the nurse data from the UK study was added to the APN global data as well. For those of you who are interested in statistics, we used various bivariate tests, so Spearman correlations, one-way ANOVAs, and the statistics used in the study were included in identifying the data conditions that might undermine interpretations and concerns. And we made sure that we used a number of non-parametric techniques to increase statistical validity. Now, I'm a qualitative researcher, so I'm very interested in perceptions, experiences, richness of data. So please don't ask me too much about the statistics, but I am going to share a little bit about some of the quantitative findings that we had. So in the study, the median age was around 47 and a half. We had most of our participants, 67% there, having masters, nearly 15% doctorate, and 11, nearly 12% having bachelors. Interestingly, the age range was 20 to 81. What I found through my international work is that many practitioners in the States actually work till ages where I would hope to maybe be retired. And I understand that's partly due to limited pensions. Majority of the participants were women, and the majority of the participants were nurse practitioners or advanced clinical practitioners, with a smaller number of clinical nurse specialists. So we used the ICN definition for advanced practice nurse, and people checked the box to say that they met that criteria. And we had a small number of students that were participated that we wanted to include to see what some of their views were. So again, thinking about the quantitative statistics. So for the mental well-being subjective score, we had a medium score of 49, and I haven't got all of the variables on the screen for you, but what I wanted to highlight that were the scores were meaningfully lower than typical scores in other studies, especially pre-pandemic. Again, for the Connor-Davidson, the scores were meaningfully lower than typical scores in other studies. And for the Facet spirituality score, we had a moderately small association between participants who had faith and resilience. And interestingly enough, that was higher in countries like the US and Canada. So if you have a particular faith belief, it may increase your resilience. But we can't generalize on that study, and we would obviously need to investigate that much further. I'm just going to kind of summarize some of the quantitative. So in the pandemic, overall, participants reported meaningfully lower scores of resilience and emotional well-being. What, for me, was particularly worrying was that in phase 2 of the study, further down the line, those scores didn't increase. Now, the significance of that is normally when we hit stress, crisis, difficult, challenging times like the pandemic, we'd expect well-being and resilience to probably drop, but then there's usually a bounce back effect, and that hasn't happened for participants in the study, which means that we really need to think about how we support each other in terms of our well-being and resilience. What was also interesting is that those countries who have a well-developed advanced practice nurse role, for example, Ireland, the UK, the US, reported lower resilience and well-being compared to countries where the APN role was still being developed. And again, we're not sure why that would be, but it may be something about that early enthusiasm and motivation of the APN roles when it's in its infancy. For us in the UK, we had significantly lower levels of well-being, resilience, faith, and meaning compared to other countries, specifically the US and Canada. However, as I said, the only real difference for the quantitative score was the faith measure, and that was particularly evident in the US and Canada. Each of the scales have significant positive associations with the other. So as I said, this was a mixed method study. We had qualitative questions that we wanted to ask APNs around. So we wanted to think about how APN was affecting them and how they practice. We wanted to think about coping strategies. We wanted to think about what's been most helpful, how APNs and nurses supporting each other and other health workers, what gives people strength to continue their work, how APNs manage the stress that they're experiencing, how COVID maybe changed them, and did they think that their contributions were being acknowledged? And finally, we wanted to ask about what support APNs feel that they may need post-pandemic. So in general, unsurprisingly, there was a mixture of positive and negative responses. There was obviously for all of us that massive move to adaptation of technology, which some APNs found really, really positive, some APNs really struggled with. There was a recognition that for some, their confidence was challenged beyond limits, whereas others felt that they grew in their confidence and their knowledge and skills. There was recognition of ongoing verbal abuse from patients, and a recognition very early in that pandemic was the fear, the stress, the anxiety about the unknown, what was happening, how we deal with that increased patient load, increased morbidity, increased mortality. There was also a recognition that there was a negligence in terms of support for staff and sometimes lack of management. We know that COVID impacted us all physically, mentally, spiritually. We know that there was that increase in workload, changes in role, moves to virtual communication, changes to service delivery. And for some APNs, that led to burnout, it led to compassion fatigue, and still is causing significant impact in our APN community. Unsurprisingly, support was something that kept people going. Having colleagues who would ask about their day, family that would support them, talking, exercise, the recognition of the impact that their care have on patients. And I'm going to share some slides with you with some illustrations of a UK artist. And these are courtesy of one of my colleagues, Laurie Spears, who shared at the ICN Nurse Practitioner Conflict. So these are some of the responses we had related to fear and anxiety. I saw the fear in the eyes of my colleagues working without protection during those first weeks. A lot of fear was about getting infected and transmitting it to my family, uncertainty. I worry about my children becoming ill, having rare complications or infecting other adults they come into contact with. I worry about dying and leaving them without a mother. Obviously, there was a massive stress in those early days, lack of PPE, lack of protocols, lack of procedures. And APN faculty, as well as researchers, as well as retired nurses, were all diverted back to practice. There was obviously that changing tableau of information and response. And for me, I was so proud of our profession for rising to those unrelenting and unreasonable demands. We needed the support of our colleagues, keeping an eye on each other. We are all better at taking care of each other, at taking over a shift when someone else was worn out. Teamwork, debriefing with colleagues, prayer, mindfulness, meditation helped, talking to peers, amending practice environments. But it wasn't always the case. One colleague said, "I have not found work colleagues in the least bit supportive. Work people have been largely selfish. As for management, we got 3 sandwiches." Resilience and well-being. There were so many different emotions that people felt. For nurses, and we recognise the intensity of the number of emotions as sorrow over the need of those who died needlessly, anger over misguided ideas about vaccines causing family rifts, joy over babies born despite obstacles, and amazement at how people have adapted to those extreme changes caused by the viruses. And the resiliency of APNs was celebrated. We were lauded as heroes and praised for compassion and caring. The work we have always done. It was almost as if it was the first time that APNs were being seen. And, as time's gone by, there is so much more that we need. The platitudes, the clapping, the support, was, a unprecedented thing that was seen across the world. But we need more than clapping. We need that support. So for all of us, I think we would acknowledge that advanced practice nursing a clinical practice has changed forever. Our areas mainly have moved into technology that maybe would have taken us 10, 20 years. We need to acknowledge the contribution of APNs, the scope of practice, what we did to support the clinical practice, and recognise that clapping doesn't pay bills. We need more than simple self-care solutions, and building resilience requires a comprehensive research approach that can be best guided by us. We need to say what it is that we need. So what we did learn from the pandemic, and what was more importantly, what is our response? What do we need? As APNs, as leaders in the nursing profession, how do we begin to move forward? How can we change and facilitate authentic practice and change? We know that many of our clinical practices aren't going to change and things aren't going away. And some of those are fantastic and will really help to catapult our profession. So for us, many of the implications we found through the study is that APNs were disproportionately exposed and infected, like nurses, with COVID. We faced increased practice-related demands, and our ability to cope well in stressful environments is related to resiliency and emotional and spiritual well-being. And although we're now down the line from pandemic, we still need support. We need support to prevent APNs becoming seriously unwell with mental health problems, physical health problems, burnout, compassion fatigue, and PTSD. And many of my colleagues that I talked to who were really in the midst of the responses in secondary care, in primary care, are still struggling with some of the things that happened and haven't had the opportunity to talk, to receive support. So, thinking about resilience, what is it? How do we build it? How can we support one another? So resilience is the process of negotiating, managing, and adapting to significant sources of stress or trauma. Simply speaking, it's about having that bounce back. And as I said in our study, phase 2 showed that APNs had not had that bounce back towards the end of the pandemic. Increased resilience is often viewed as a protective factor against the negative impact of stress. And it's dynamic. It's where we use our resources to cope and learn from adversity. But for me, the big question is, using the term resilience, does it imply that it's down to us as individuals? And of course, we have a part to play in our own resilience. But there is a lot that needs to be done in terms of policy, in terms of organisations, and also how we as an APN community pull together and support each other. So have a think about what your role your organisation has. And other work that I have done in terms of spirituality and spiritual well-being talks about that if our organisations are not organisations that have an open and transparent way of working, that support staff and listen to staff, then it's very difficult sometimes to really support our own well-being. So in terms of resilience, we have a number of models that we can look at. Two of the main ones are the engineering model, which looks at how we return to a steady state, how we bounce back, and focuses on the individual. The ecology model, however, focuses on the complexity of the world we live in, the role of our communities and organisations, focusing on positive outcomes that can result from instability within communities, teams, organisation. And they require an organisation and mobilisation of resources and multiple different responses. So we need to think about what sort of environment we work in. We may have worked in different places with different similar stresses, but the impact on us may have been very different. So thinking about our approach to resilience, there is not one size that fits all. So whether you're working clinically in education, in research, or in policy, we all have times when we feel that we're pushing and pushing and pushing. And at some point, what's going to happen when work feels like this? I am very much a researcher who believes that our research should make a difference, that we should respond to our participants in a way that offers something that may be of help and support, and particularly in the advanced practice community. So last year we moved to an implementation stage where we offered resilience-based clinical supervision to advanced practice nurse trainees and also advanced practice nurse clinicians. And the reason I chose a resilience-based clinical supervision is that it's about promoting compassion to ourselves. So it's different to clinical supervision. It's a supportive forum that can increase our ability to respond positively to the emotional and physical demands of our roles. And it was developed by the Foundation of Nurses, originally for student nurses and nurses, and has now been used successfully with APNs. So it is a process that, as well as being supportive, specifically increases our ability to respond positively to the demands of our role. It enables us to develop strategies to raise our awareness of well-being and pays attention to the complexity of the systems that we work within. So some of the outcomes of resilience-based clinical supervision include individually how we take time to maybe be more mindful, how we manage distress and stress, and how we learn to reframe. So I'm sure many of you are like me, that when things are difficult, the first person we start to blame is ourselves. We become very critical. And resilience-based clinical supervision is about challenging that and recognizing the complex difficulties that we may face that are not necessarily all down to us. It helps build relationship. We usually have 6 to 8 participants where we can have critical dialogue, supportive relationship development, and we have reflective discussion. And after COVID, we very much focused on the impact of COVID for participants. And in an organisational approach, if they're willing to release staff for resilience-based clinical supervision, it's giving that protected time. It reinforces that we value staff and acknowledge the consequences of our work. And it requires them a commitment and a mobilisation to provide the resources. Some of you may have heard of a social scientist called Brené Brown. I love her work. She talks very much about the gifts of imperfection. And like many of us being self-critical, many of us also expect ourselves to be perfect. And the more we recognize who we are in terms of our vulnerabilities, in terms of our humanness, the more we're able to address our well-being and resilience. And she suggests that we cannot give to another to a greater extent than we can give to ourselves. So unless we provide time for ourselves to restore, to receive support, to become more recognizant, I can't say the word, sorry, but of our own need for compassion and resilience. So just for a couple of minutes, I'd like you to think about this alpaca scale. Where do you feel that you are today? So we use many of these scales in resilience-based clinical supervision, and I like them rather than just saying, how are you today? this kind of brings out some conversation. So are you feeling that you want to hide away? Are you feeling in a pretty good place with your buddy? Are you feeling confused? Are you feeling sad? Are you feeling buoyant? So just have a think about how you are today and maybe a little bit about what you need. So spiritual well-being, I haven't particularly focused on this talk on emotional and physical well-being because I think they're more easily understood. But spirituality and spiritual well-being may be less understood and talked about. So spiritual well-being. So I simply suggest that spirituality is about what brings each of us hope, meaning and purpose. I see this as different to religion. I think that, you know, for some people, their spirituality is informed by their faith. But for many of us, it may be our work, it may be our family, it might be our sausage dogs. So hope, meaning and purpose are fundamental parts of spirituality for ourselves and also for our patients. Spiritual well-being relates to the way we live and how we perceive and relate to the world around us. And we know from our studies and from other literature that advanced practice nurses who have a higher level of spiritual well-being are more likely to be resilient and better able to tolerate psychological and physical stress. And we also know that spiritual well-being increases job satisfaction. And one of the things we found from our study were there were people were saying that they were intending to lead, that they were struggling with job dissatisfaction. And we've actually just starting a new study this year looking at advanced practice nurse job dissatisfaction globally. And if you'd like to participate, do please let me know and I can send you the study. So we also know that those who have a higher level of spiritual well-being are likely to integrate spirituality into holistic care. So they'll offer a biopsychosocial spiritual approach where they consider what gives patients hope, meaning and purpose. I've talked about this before in this forum a few years ago, but I developed a framework for clinical practice, specifically for advanced practice nurses, called the Availability and Vulnerability Model. And this developed out of my own investigations and searches into spirituality, but also my PhD study into perceptions of spirituality by nurse practitioners. And again, like my definition of spirituality, this is not a rocket science model, it's simple. It talks about availability, firstly, being available to ourselves, continuing as APNs to be self-reflective, self-reflecting, and embracing spirituality broadly and integrating it into our own journey. It's about welcoming others and offering time, acceptance, and understanding, being truly present and listening attentively. So not just physically available in time, but emotionally availability. It's about availability in the care and concern we offer others by creating a safe place where they can share their stories with us, and also being available to develop professionally in response to the needs of those in our care and in our communities. So availability is much more than being just there. It's that choice to engage with our patients and our colleagues as fellow human beings. Vulnerability is often seen as a weakness, something to avoid. But in this context, it's intentional vulnerability to accept the vulnerability of our roles. The reality is we'll never know it all, and being willing to accept that and to acknowledge it with our clients. To be accountable, to engage in supervision and reflection, and being willing to accept constructive criticism. It involves us sharing uncertainty with those in our care with a way that's open, transparent, and within our professional and personal boundaries. It's about being willing to advocate for those in our care, questioning authority, and putting the best interests of those we care for at our heart. And being vulnerable and authentic in our care. So Vulnerability in this instance is positive. It's about, not being defensive when we're challenged, being willing to share our uncertainties with those around us. And we've developed some tips for spiritually competent practice, which is sometimes easier to understand than spirituality. So, trying to be aware of your own spirituality, what gives you hope, meaning, and purpose. Listen for and be attentive to our patients, raising issues that relate to spirituality. So, what does their illness mean to them? Being fully present and attentive to those that we're caring for. And we can do that when we're involved in tasks as much as we can within our consultation. And showing people we respect them as fellow human beings. And Martin Buber, a therapist and a theologian, talks about an I-thou relationship rather than an I-it. So I always try to think about my consultations as being a privilege, being able to share as a fellow human being. It's about person-centeredness, and it's about reflection on how we've dealt with patients and colleagues, whether that's been compassionately or not. And, we're not all able to be in that place where we, carry out our care in the ways that we'd like to, but reflecting maybe on why we haven't been able to do that is important. So, in your own time, take time to think about, what gives you your life hope? What gives your life meaning? What gives your life purpose? And what informs your personal values? So, I very much believe in my work as a vocation. I believe in my work as a privilege, especially as a nurse practitioner. And my work does give me hope, meaning, and purpose. But many other things are important to me as well. My family, my friends, my sausage dogs, nature. So I'm going up to Northumberland tomorrow to walk on the beach, to give myself some time to restore. Because I'm often have reflected, and I was talking to Jacqueline about this last week, I talk about spirituality. I research and about spirituality, and I include spirituality in education. But my work often becomes so busy that I don't take time to reflect. I don't take time to be compassionate. I don't take time to always kind of take the time to restore, to be compassionate to myself. And I think that's something that many of us will resonate with, because we just kind of are almost on that treadmill or that hamster wheel. And how do we stop? So I'm going to take time tomorrow to sit, to walk, to reflect, and to try and start not working in the way that I work, because that doesn't actually reflect my personal value. I do believe that we should care for each other, that as nurse practitioners, that we should be able to stop, that we should be able to care for ourselves. So have some time to think about that. And maybe think about how where your guiding principles come from. I was talking to a student a few weeks ago who said to me, the values that my parents brought me up with, I've challenged now, and I've rebuilt my own values that reflect the way that I want to live my life. So your values may come from your childhood, they may come from the way you've been brought up, they may come from your experiences. So maybe try and take time to make a list of 3 or 4 things that are important to you, and take time to think about how you can maybe be more self-compassionate, how you can support your own well-being. Because, it's clear to me in our NHS services in the UK, we don't often care for our staff in the way that we should. I was talking to a colleague yesterday when I was in clinical practice, and they were seeing 40 patients a day, one after another, no breaks, people are off sick. And the demands from our patients are becoming greater and greater, as are the demands from our organizations. So I've also put on some guidance and bedtime reading. If you have time, do think about looking at some of these websites. So Paul Gilbert has done a lot of work around the compassionate mind. I would challenge you to look at Kristin Neff's website, because she has a survey that you can complete about how self-compassionate you are. And I've done a huge amount of work over the years on compassion, self-compassion, and I did the survey a little while ago, and I was shocked to see that I'm not very self-compassionate. And as I talked about earlier, if we're not self-compassionate, it's very difficult to give to others. And then, as I said, Brené Brown, I really enjoy her work. It came out of research as a social worker. She's done a lot of work about the power of vulnerability. And this TED talk that she did on the YouTube here was one of the most widely watched TED talks. She also interestingly did one on shame. And again, that was one of the most widely watched TED Talks. And we don't often talk about shame and the way that some of us carry shame, but that's for another day. But do think about kind of looking at some of these resources and thinking about how you can support yourself and your colleagues, and think about maybe some of the things I've talked about. Resilience-based clinical supervision is a champion and cascade model. So once you've done the training, you're able to run groups, but then people who come to the groups can cascade that down to their organizations. I've put some of my papers there. You can have a read about the studies if you'd like to know more about those. We've had the quantitative elements published. We're trying to get the qualitative responsive study, and there's my contact details there. So I'm going to end for now and hope that we can have some general discussion. And I hope that it's been useful and maybe has some resonance for you.
Thank you so much, Melanie. That was just a superb presentation. I very much enjoyed it, and I'm sure all members of our seminar audience have as well. I suppose the key thing that we can take from it, in addition to your qualitative and quantitative findings, is the necessity for us all to be more kind to ourselves, to restore, to refresh and replenish our energies. Now I'm just going to have a look here in the chat function and see if we have, because I know one question came in. Why is it not coming up on my function here? Oh, here we are. Yeah. Okay. So this is from a student, Melanie. Nice to talk to you. I am Anyang, who just graduated from TCD, and my dissertation is about mindfulness-based stress reduction. So I'm very passionate about spiritual research. My question is about, since your research, you have found that AMP's well-being and resilience received a huge impact during COVID. So next step, will you guys look for potential interventions to address the issue? For example, cognitive behavioral therapy.
Yeah, thank you so much, and congratulations on graduating, and your dissertation sounds fascinating. So yes, the intervention stage has been the resilience-based clinical supervision. So we piloted it last year with 4 groups, 2 global groups and 2 UK advanced practice students. And we've just launched a second round of global resilience-based clinical supervision. So our aim is to have the facility for 400 advanced practice nurses to access freely resilience-based clinical supervision. And I didn't focus massively on it, but there are elements of CBT within that. There's elements of mindfulness. There's elements of distress toleration. And we focus on a number of different structured elements over 6 sessions that enable advanced practice nurses to feel that they have the skills as well as the space to develop and reflect on what they need. So that is, as I said, something really important to me as a researcher, that actually that we make sure that we do have implementation stages, that we do offer support, and that we do think about, well, we've been privileged to gather all of this data from participants, so how do we support you? Thank you, Anyang, for the sausage dogs as well. I'm just trying to get one of them to stop barking. She's behind me.
Okay, thanks for that, Melanie. Does anybody else have any other questions that they would like to pose or like to ask? I think what I'd be interested in asking really around the study, Melanie, is basically about, the needs. Did the participants go into details about the specific needs that they have?
There was lots of detail about needs, and I have to say, I mentioned that I'm a qualitative researcher, and I started the analysis myself, and I was absolutely distraught reading some of the responses of participants and their needs. So there was a big mix from practical needs. So there was one US nurse practitioner who was living in a car with her kids, had lost her home through COVID, during COVID. There was recognition of a real need for managers to do much, much more to provide support. So some organizations offered kind of psychological support to their employees, some offered nothing. One organization that is a social enterprise have a very values-based approach, and so they'd put in specific amounts of funding for people to access massage, well-being. There was a real kind of dissonance, I guess, between the first phase where people were saying, oh, it's great that people are clapping for us, but then the recognition in phase 2 that actually we need more. We don't need just clapping. We need actually people to recognize advanced practice nurses for what we do. We need to have salaries that reflect what we do. We need to have working hours that are feasible. We need to have teams that support each other, and we need to make sure that we don't work in silos, that there is much more support across the organization. So there was a real mix between physical need, emotional need, organizational changes that needed to be made, but also policy, a change in policy to actually really reflect the work that APNs have been doing for years, but is often seen as invisible work.
And was there anything that focused in around the mental health needs of the population?
Massive. So there was a lot of talk about, even before the pandemic, people were at breaking point, that people were really struggling, that there was really not very much recognition of how the work that we do has that massive impact on our mental health. The need to be able to say that we're struggling with our mental health, but many participants said, I can't say that. I need to just say that I'm going to be off work with a physical cause. And, that's not new. We see that over and over again when we look at burnout, mental health. There's still that stigma and shame, which, although we've challenged massively, people really, really still struggle with. And there's still the issue of how our colleagues view us. Some people talked about the fact that, they were really struggling with their mental health, but they couldn't say that for fear of how their colleagues would judge them and respond to them. So, I often think we're moving on leaps and bounds in terms of mental health, but then I look at how people view how they're seen when they talk about their mental health. And I've just done another big study looking at mental health service users. and that shame and stigma is still alive and well.
Yeah, the stigmatization is huge around the whole issue of mental health, and that's why a lot of people won't disclose. And we do know, obviously, from the literature and from the research, at least 15% of the population are suffering from some kind of mental health issue at any one point in time.
Right.
And then it's difficulty for them to get help because they are afraid of the bias and the stigmatization and the stereotypical views that people have around the mental health issues. Any other comments around what the participants said about the kinds of organisational supports that they may be seeking to make sure that they can actually build up levels of resilience in the workforce?
Yeah, so I think there was a lot of discussion about how organisations do need to make significant changes, that organisations need to have kind of from the top down a compassionate and kindness in the way that they treat staff, where the way that they communicate, in the way that work is allocated, in the roles that people have. There's, recognition that there needs to be more time for people to have supervision, time for people to access support for their mental health if need be. Some organisations talked about really creative ways that practices and organisations have tried to address things. One of our participants talked about that their organisation had a feel-good football team, which was for healthcare workers and patients in a mental health trust. So there was kind of different ways that people articulated, but I think there was also a real frustration that it's often seen as, we're not going to invest money into these areas, that there's so many other things that need prioritizing, and that actually the workforce will keep working because that's what they do. And the levels of burnout and compassion fatigue are just going through the roof. I mean, some of the recent statistics are phenomenal in terms of job dissatisfaction, burnout, compassion fatigue. And the recent study was talking about, I think it was 2022, that at any one time, 23% of the workforce don't feel that they're well enough to be at work in healthcare. Yet we just push ourselves and go.
Yeah, Michael West referred that to in his report on Courage to Compassion. It was very much to the fore in relation to that. So I suppose really, we have a big remit individually to ourselves as well as organisations to us. So I suppose we need to develop an increasing awareness of our values and to clarify what they are. And then we need to have an understanding of the professional and the spiritual and psychological dimensions of our well-being in order to keep ourselves safe. And then sometimes that can only be achieved then when we kind of coalesce the private and the public dimensions of who we are as people, and to try and balance those out as much as possible, to engage in authentic relationships and authenticity that you referred to. Can I just ask you finally then, Melanie, around your work, are there many people using your model on availability and vulnerability within the UK or elsewhere?
So it's really difficult to find out. So at the moment, we've just done a study looking at advanced practice nurses' perceptions of spirituality. And part of that study was looking at whether spiritually competent practice is a useful concept rather than spirituality, and also is availability and vulnerability useful. So we have done studies with mental health clinicians, mental health service users about utility of the model, and that's been shown to be really useful. We have a colleague in Israel who has integrated the model into their curriculum. So there are pockets across the world who have used the model, and I wrote a book, edited a book a few years ago about stories of hope, advanced practice nurses, and spirituality. And a number of the authors in that are using availability and vulnerability. And I think even if they're not using it under that framework, I think the concepts would be things that people who have a passion for integrating spirituality into their practice would recognize. As I said, I don't necessarily feel any of my work has been kind of rocket science. I'd say, it's something that is part of humanity. And if we go back to the basics and the reasons why we entered the profession, they are to support our patients holistically. But I think it's just bringing it more to the fore. And I do think, in my own clinical practice, when I am much more cognizant of that whole approach to biopsychosocial spiritual, my consultations flow easily. I am much more content in my work. I feel that I've made a difference. And that's in those simple approaches in terms of turning away from the computer and just saying to your patients, how can I help? And being there fully present, even if it's in that short period of time, those all do make a big, big difference. And I do find for me, it has changed my kind of well-being and resilience levels massively by working in that way. And being kinder to myself. And, if I have a bad day, it's okay. We all have bad days.
Well, thank you for sharing all of yourself with us today and for creating meaning in the work that you're actually doing, because that actually gives us more meaning in terms of what we need to do going into the future. So before we finish up, I would just like to share with you our next webinar that will be taking place now in March. And this is Professor Sylvia Caldera. She's an associate professor in Lisbon, and she will be giving a presentation on spirituality and resilience. So we're very much looking forward to that, and that will be between 1 and 2 GMT time. And then in addition to that, then I would like to share some exciting news. So we will be rerunning our Spirituality Research and Innovation Healthcare Conference in June of this year. And the title of the conference is The Spiritual Imperative in Healthcare Perspectives on Interdisciplinary Approaches to Nurturing Resilience. So the conference is actually set up on our events page on the School of Nursing and Midwifery website. And the abstracts are actually open, and we have a terrific lineup of speakers, as you can see. So Melanie will be actually instigating the opening address. Dr. Stephen Costello will be talking to philosophical aspects of resilience, and Dr. Porrick Hurley will be examining contemplative approaches with us. And then we have Dr. Austin Del Osta, and he is the director of the first self-care academic unit in the world, which operates out of the Imperial College in London. And he will be speaking to us around models of self-care and associated impact on resilience. And then we are very blessed to have Professor Cinda Rushton, and she is a bioethical professor based in the US, and her area of expertise is all around moral distress. So she'll be speaking to us on that and its impact on resilience. And then we also have Michael West, Professor Michael West. He's coming to us, and he'll be examining his report on Courage to Compassion and what we can do and what organizations can do to rectify that. And then we also have Professor Mary Jo Kretzer from the University of Minnesota. And she's the director of spirituality and healing there in one of the centres, and she'll be talking to us about how we can best promote well-being in relation to increasing our resilience. So we're very much looking forward to this. So please have a look at our website and see if you'd be interested in joining us on the 6th of June. So I will close today's session now, and thank you very much for joining us. And we hopefully will see you soon next month. Thank you again, Melanie. Much appreciated. Take care. Thank you.